And thank you everyone for connecting to this webinar of the European Respiratory Society. It's a great pleasure to have Professor Giovanni Battista Migliori as a speaker today. Probably for most of you, he would not need any introduction, but for those in the audience who might not know him, I will just say a few introductory words. Professor Migliori is a physician and researcher with over 30 years of experience in tuberculosis research. He has conducted research mostly in Europe, but also in other continents, in Africa and in Latin America. He's the director of the World Health Organization Collaborating Center for TB and Lung Diseases in Tradate in Italy. He's honorary professor at Queen Mary University of London in the United Kingdom. He's the chair of the Global Tuberculosis Network, GTN, and he's also the editor-in-chief of the International Journal of Tuberculosis and Lung Diseases. Today, Professor Migliori will speak about a very hot topic, which is the interaction between tuberculosis and COVID-19. The two infectious diseases that will cause more deaths in 2020 and 2021 for sure. During the presentation, Dr. Migliori will make some questions to the audience. And since we would like an interactive presentation, please type the answers in the chat box and we'll be able to provide some answers to Professor Migliori. Please make sure that you select in the chat box, you send the comments to all panelists and attendees, because by default, it only shows all panelists. So make sure that you select all panelists and attendees so we can all see everyone's answers or questions. We will have a 15-minute Q&A session after the presentation. So we will be able to ask questions directly to Professor Migliori, and you can actually type them down during the presentation in the chat box. So without further ado, Professor Migliori, the floor is yours.
Thank you very much, Alberto. Warm welcome to everyone. I hope that the sound is good as it was when we tried it. And today, okay, I have no real or perceived conflict of interest on this topic. Let me see. There is, okay. Voila. Today, we will start speaking about the impact of viral diseases on the lung. We will then discuss similarities and differences between COVID-19 and tuberculosis. We will briefly revise the scanty initial evidence, which was available before that the Global Tuberculosis Network started addressing this issue and publishing the first evidence. And then probably the reason why I was invited here, I will provide some evidence from the two studies that the Global Tuberculosis Network is presently undertaking. The first on clinical evidence, and we will have a special, let's say, discussion on the available evidence on mortality, and then on the public health evidence with the impact on health services. And then we will have some conclusions. So feel free to pose any question also during the presentation, and Alberto will help and interrupt if necessary. So impact of viral disease on the lung. And I'll prepare now a question whose answer is probably rather obvious. Which example of viral disease we can consider to predict interaction of COVID-19 on TB? So if you want to answer, in your opinion, which the model we might have in mind to try a parallel and see which points may be similar or different. And if you want to answer in that, then this will help. Otherwise, I will proceed, and then eventually Alberto will comment. So waiting for this, I will eventually go on. There are no questions, right? No answer, right, Alberto? Let's go on.
Yeah, no answer so far.
Very good. So the answer was there are several possibilities, but very good. Someone answered $1 million for Dr. Vivendra and others, right? So it was TB HIV, and we was this interesting consensus document, which was published in last year in the European Research Journal, which makes a little bit the point on the different viral diseases. There are others as well, but I think TB HIV is the most known because of its impact on also, but on public health, and much on TB COVID is still to be fully understood, and is the reason of the studies which we are undertaking, and also for this webinar. It's a bit slow in reacting to the bottom. Very good. Sorry. Yeah? Okay. This slide is taken from the Hans Riedel book, and is very simple of TB transmission. So there is exposure, there is latent TB infection, there is TB disease, and eventually death. And there are risk factors which promote the movement to the next step. This is largely unidirectional, right? In reality, several risk factors, and HIV is considered probably the most powerful, contribute to impair the host defense, and then favor what is summarized here. So the infected individuals can have a boosting effect, can have a kind of help to evolve towards TB disease, no? The so-called breakdown rate. And we know that when the HIV, when the CD4 counts goes down, okay, the risk of developing tuberculosis tends to increase, and this has been one of the mechanisms which has generated the impact that HIV had on TB. In addition, of course, the importance of the antiretrovirals, which restoring the immunity and bring the CD4 cell count can reduce this risk. And there is the entire very good. Okay, Katerina is just putting the history of the story of antiretrovirals. We will discuss about that. And then there is the issue of antiretrovirals which interfere with anti-TB drugs, in particular with rifampicin. That is a specific issue which is relevant for TB HIV. This is an historical slide which shows why in, for example, sub-Saharan Africa, the impact of HIV on TB was more important than in Europe, for example, because same age groups were involved, and therefore the potentiality for interaction was much higher, while in Europe we had more young individuals with HIV and older individuals with TB, and the interaction was less important. This is super well known. And in terms of the effect, we know from history that a person without HIV has a 10% lifetime risk of developing tuberculosis. Half it is concentrated in the first 2 years, while in the presence of HIV, the risk is 10% per year up to about 50%, so it's much higher in absence of antiretrovirals, as one of the participants correctly said. Now, the slide is not super good, but the issue here is, we will understand better with the next slide, that basically infection can evolve rapidly into TB disease. it can stay for a while and then evolve gradually, but can also come back. So the recent attention has been, let's say, concentrated in saying that there are different stages, or mainly we can say didactically, there are different stages from latent infection to TB disease, because in reality, this is a continuum, and this continuum is bidirectional. So there is also possibility to come back. And this is maybe a little bit more clear as this will appear soon in Brief, the journal of the Education Journal of the European Respiratory Society. And we see, of course, there is TB infection, and the movement from TB infections to disease, we can pass to subclinical or clinical disease based on the availability or not of signs and symptoms, passes through a phase which has been called incipient TB. But the interesting thing is that this movement is bi-directional. So it's also possible that someone which is infected goes back and become uninfected, or someone who has incipient TB can also go back. And we know HIV is powerful in boosting this, as we have seen, right? So the overall risk, instead of being 10% in life, is 50% in life, 10%. And this is not fully clear in COVID, and we'll try to give a little bit of evidence during this presentation based on what we have from previous studies. I'll try to move to the next slide. Voila. Okay, sorry. Okay, now let's look at the second issue, which is, let's say, a parallel between the two diseases with the similarities and the differences. This is to let you know that the arguments that I'm presenting here are summarized in this review, which has been recently published this year, 2021, in Pulmonology, which is free access. So you can also have access to this and give a look. Which are the main similarities between TB and COVID? This is a letter published in the European Respiratory Journal by Riccardo Alagna and other co-authors. The first one is the stress on health systems. We know the stress on health system is much more acute for COVID, but also TB can, in certain circumstances, create stress on health systems. There is the need for rapid testing for both rapid testing exists, and there is need for both diseases on public awareness to contribute to control the disease themselves. Both diseases can create stigma, and we can say that for both diseases we need better data. So we have good data from TB through surveillance, and now also from COVID. But some of the, let's say, main questions still pending for both diseases require variables which are not usually present in surveillance. There are also differences in funding. So funding is chronically limited for TB, has been released much more for COVID, a bit chaotically, but for sure there have been unprecedented funding, for example, which has created the possibility to have in 1 year a vaccine. And there are differences in policies. For example, TB has well-established policies, which are not always supported. And we are just now looking at the development of policies on COVID. And we don't have, at the moment yet, a real TB COVID-19 management guidelines, because the issue is still under development. In this other, this is an editorial by Masudara and others, which was published in the Journal of the Union. There is again a nice parallel between the two diseases, with focus on prevention, on rapid diagnosis, on the possibility of being cured. Although for COVID, we are not still pretty sure by which drugs we can really treat it. And there is more on availability of vaccines, etc., etc. What is sure is that there is a large economic impact, which has been quantified to be around $12 billion annually. And for sure, it's very large as well for COVID, but this has not been quantified yet, also because there are continuously new waves, which make this difficult. Before the GTN studies, the evidence was really very modest. So there were a couple of letters with some with description of individual cases like this one. And there was a first meta-analysis, which has been then published in 2020 in the Journal of Medical Virology. 6 studies from China, 3 of them in Mandarin, which are a little bit difficult for the majority of people to follow. And the TB prevalence in COVID patients was ranging between 0.5 and 4.5%, with a prevalence of TB in severe patients of 1.5%. Sorry, that was a little problem. Let's go back. Voila. And the risk is higher for TB disease than for previous, say, sequelae. And the risk of mortality in COVID patients was estimated to be 1.5 times higher. This was published before the initial evidence from the study of the GTN. And this was the first cohort. As soon as COVID appeared, the GTN is organized in 8 countries, a study that identified 49 cases of TB and COVID. Let's say this was the first cohort, and the first cohort, of course, was generated quite a lot of interest, and this was just a letter, but was cited more than 100 times in 1 year, which is quite a lot for a letter. So the patients had a median age a little bit less than 50 years, majority being males, half being migrants, majority being vaccinated, and 12% being HIV co-infected. And the core finding of this study was that TB can be diagnosed before. 53% of these patients were had TB diagnosed before COVID, but in 28% COVID was diagnosed before TB. And interestingly, in 18% of the cases, they were both diagnosed on the same week. This is because the symptoms are largely the same, and the, let's say, fear of COVID has contributed also to probably send the patients to undergo a radiology, and the radiology has then shown that there was also consistent TB. Interestingly, also, while 85% of the patients had active TB, 14% of these 49 patients had sequelae of TB. So they had residual problems after the diagnosis of cure at the end of anti-TB treatment. And in order to understand more, so the GTN has coordinated a global study, which is still undergoing, which involved more than 40 countries. And I will have at the end to acknowledge the about 200 colleagues who contributed to that. And you see the countries there. And we performed the first interim analysis on 700 cases, 706, without Lithuania, Virginia in the United States, and Latvia in this preliminary analysis. We see that TB was diagnosed before in 44% of the cases. Sorry, sometimes it's moving on its own. With a median of 79 days. When COVID was diagnosed before TB, there was a median of 28 days. This is interesting because it is among those patients where eventually we can see the importance of in boosting TB infection and eventually facilitating the movement towards TB disease. And then we had about 18% diagnosed during the same week, with 28.6% having TB sequelae, so post-TB lung disease, as this has been called. We'll come back to this. The general details, the majority of patients are males, 72%, with pulmonary tuberculosis, 84%, with bacteriologically confirmed TB, and you can see here how TB was confirmed, and the majority was drug susceptible. In terms of signs and symptoms, the majority of patients reported fever, dry cough, and dyspnea. And we see that typical symptoms for COVID, like taste disorders and olfactory disorders, sorry, it's moving on its own, okay, were, okay, sorry, let me go back to the next slide. Okay, olfactory disorders and taste disorders, which are considered pathognomonic of COVID, were available in less than 10% of the cases. Then, in terms of radiology, we had two possibilities. Sorry, it's strange. It's going on its own. In terms of radiology, we had two points. But I don't understand. It's going on its own. Let me go back. So radiology. Radiology. So the radiology at the moment of TB diagnosis, we see that the majority of patients underwent a radiological examination, 96%, and a good proportion of cases we can see here had cavities, while in COVID-19, 1/5 of the patients have not done any radiological examination, and 84% had typical or atypical ground glass opacities, which confirm their importance for the diagnosis of COVID. In terms of treatment, on the left panel, we see the drugs which have been, it's like a picture during the first wave. The majority of these patients were entered in the database during the first wave. And the most popular drugs prescribed were azithromycin, with some other antibiotics, anticoagulants, hydroxychloroquine, and steroids, as well as antiretrovirals. And we will discuss further about this. 1/3 of the patients needed oxygen and more than 10% ventilation, and we will come back to this. In terms of treatment and outcomes, as about half of the TB patients were still undergoing their treatment, so we cannot say much on this. What we can say is that we had a mortality of about 12%. We'll come back to this. 9.1% of the patients were hospitalized, and 41.8% were discharged alive. Now, another question, which is whether COVID-19, you think, is able to increase progression from latent TB to TB or not. So, what do you think? We saw a couple of yes.
Mostly yes.
Very good. Mostly yes. Okay. This is in reality a difficult question to answer, and we try to propose the evidence that we have. Voila. Okay, so the answer is probably no, according to the data we have. What we did were we looked to the 67 patients who had a COVID-19 diagnosed before TB, and we selected the 33 which were diagnosed at least 30 days before. So why 30 days? Because having HIV as a model, we consider this a sufficient time to develop TB given infection. Among these, 31 had pulmonary tuberculosis. Among the 31, 24 provided full radiological information. And out of these 24, 11, which are about half, had cavities. And to generate cavities, we need much more than 1 month. And we had a single patient with that, which among in this group, which had a positive quantiferon 1 month before, so which potentially could have had, let's say, COVID as a trigger. This is not the ideal study to show this, because we need a longitudinal study, which over time demonstrates this. But the initial evidence that COVID can have less strong power of boosting this than HIV. The next question is if you think that we have finished our work when the TB patients are cured or finish their treatment, or when COVID disappears. Or you think that we might have further work to do. You are already seeing the answer because it's going on its own. So it has a soul, this presentation. Do we see answers, Alberto?
No, has been said by a few participants.
Okay, we have not finished our work. Huh? This is what you say, and you are right. Yes. Why it is? This because it has been demonstrated that there is a condition which has been baptized PTLD, post-TB lung disease, and it's possible also to have post-COVID sequelae. In particular, after TB, it has been demonstrated in a certain proportion of patients a decline in pulmonary function, and also the sequelae can have an obstructive or restrictive or a mixed pattern if we consider spirometry, and this can hamper also the exercise capacity, for example, climbing stairs, etc., and the quality of life. Sorry again, it's crazy. What's going on? Okay. Which is the prevalence of this phenomenon? So it ranges between 13% and 68% among new cases, and between 75 and 96% in MDR-TB cases, which have usually repeated treatments, so more opportunities for the lung damage. The mortality of for TB survivors can be up to 3 times higher than that of the general population, and there is evidence that pulmonary radiation is effective in these patients, and there is also research undergoing to see what is going on for COVID. Some evidence for TB, there are several papers. So, for example, this paper from Dina Viska in the Journal of the Union, which is the proportion that suffer of this post-TB lung disease, and provide evidence on the effectiveness of rehabilitation. There is interesting papers like this from Brian Allwood, which gives a proportion of the obstructive, restrictive pattern, etc. And this is also very important There is a document from the Union published in the International Journal of Tuberculosis and Lyme Disease in a specific meeting, which makes the point on post-TB lung disease and provide set of definitions, methodology, etc., etc. So it's the first attempt to define this condition and let's say propose further actions. I will come to this very rapidly. Again, European Respiratory Journal, the effectiveness of pulmonary rehabilitation, and from Mexico, Marcela Munoz Torrico in International Journal of Tuberculosis and Lyme Disease, a picture of the functional impairment in patients from Mexico. So those are examples. There are some 20, 30 papers which cover this topic. So the question is, do we need also rehabilitation for post-COVID? It is still uncertain what is the proportion of COVID survivors with this problem. It's known that there are long-term consequences varying from mild symptoms to severe conditions, often affecting multiple organs. And the symptoms involve dyspnea, fatigue, and other symptoms like depression, anxiety. They can also affect the heart and the renal system, etc. And of course, there is also for COVID an impairment in quality of life. And there is some evidence also that rehabilitation can work, like this paper from Zamponi and Dinaviska again, recently published. The next question, which is I think particularly important, is whether COVID-19 increased the mortality in TB patients and what is the cause of death for these co-infected patients. What do you think? Let's see what the participants are saying. Yes. Majority says yes, right?
Mostly yes.
Very good. Very good. Super. Thank you very much. Let's look at what the evidence is on this. Evidence on mortality. So the first action that we made as soon as we have published the cohort on 49 cases was to combine these cases with another 20 cases from another paper, which was published by Simone Villa and others in the reference hospital of Sondalo. And the situation in Sondalo is that there were 20 cases with TB. One was an old Italian with many comorbidities, old with many comorbidities, and there were 19, let's say, otherwise healthy young migrants which had no other comorbidities because they were young except TB. And one patient entered the ward being COVID infectious and rapidly transmitted COVID to the entire department. It was at the initial phase of the first wave in Italy. It was March, April 2020, and infection control was not set perfectly, etc. And the result of this was that apparently, this is the paper is in open access, we can get it, that the deaths were related to old age and comorbidities mainly. And the time to death was very variable based also on the different treatments and approaches that the physicians try to establish. Then we try to, let's say, evaluate the mortality, and the overall mortality was 11.6%, so 8 of the 69 patients was exactly 14.3% among the 49 patients of the first cohort, and only 5% in the 20 patients, as 19 were otherwise healthy, so they had TB. And in this way, migrants, being younger and without comorbidities, they died less, so it was even protective to be migrant in that specific situation. Interestingly, there was this paper which has been published in the European Respiratory Journal. Is a relatively small cohort from India, 22 patients from the Nitesh Gupta's group in India. And interestingly, the mortality was high, was 27%, right? But no TB was diagnosed among COVID-19 admitted during the first. When we undertake the study of the 49 patients, we had several counts. I remember Netherlands or Slovakia, even Sweden at the beginning, etc. They said we have COVID, but not yet TB COVID co-infected, right? You need sometimes that COVID is around to get the chance that someone with TB gets it, or that there is this interaction. And then overall, of the 1,073 COVID patients admitted, there are 2% were co-infected with TB. 13, that is 59%, had active TB, the remaining patients have sequelae. And importantly, 7 patients of these 22, 2% basically, were admitted at ICU, and all the 6 who needed invasive ventilation died. So the mortality was higher. So it's eventually country specific and related also to the quality of the services and the possibility that is there also, that was there to provide ICU to people of all age with comorbidities. This important study published in 2020 in CID was all based on COVID-19 and referring in particular to the situation in South Africa. While HIV increased the risk of death of 2.14 times, current TB increased it of 2.7, and previous TB of 1.5. So previous TB less than current TB. In this way, proposing, let's say, current TB and previous TB as a clear HIV as well, risk factors, let's say, special risk groups needing special attention for COVID-19 management. And similarly, another important paper done in the Philippines on COVID demonstrated that the risk of death in COVID-19 patients with TB was 2.17 times higher with shorter time to death, and the risk of recovery in COVID-19 was lower, 25% lower with longer time to recovery. There was also recent evidence. We had a presentation in the United States days ago, and in California, the risk of death is about 2 times higher for TB without difference for TB and sequelae. But this is the specific situation of California. Is a few days ago, not published yet. Now, the following question that we posed was, okay, the small study, introductory 49 cases, demonstrating 12% case fatality rate. Is this confirmed? Yes, it's confirmed. With 84 deaths out of 706 patients, and out of the 81 with details, 50% died for COVID, so COVID was reported as the cause of death, 37% for COVID plus TB, both, 5% with COVID, so during COVID still, before the end of COVID, but the cause of death was different, and 7% died for other reasons after resolution of COVID. So this is the preliminary evidence from the study we are analyzing. The next question we can discuss at the end of all these details because we saw 4 questions. The next question is, whether do you think that BCG protects against COVID? What do you think?
Mostly no, probably yes.
Probably yes. Okay.
But mostly no. People don't think BCG protects against COVID-19.
Answer yes. Very good. So this reflects a little bit the reality, in the sense that the ecological analyses which were conducted were non-convincing. So the ecological analyses are those analyses which are based on the, let's say, if in a given country we vaccinate or we don't vaccinate, there's a policy, and then we analyze the data, we compare them, right? And the majority of experts agree that we need to wait for the trials which are undergoing in the countries. We see the bullets there indicating when the trials are. The reason why there was hope that the BCG could protect is that BCG has a specific capacity of boosting immunity. So it's providing a certain protection also against other diseases, measles, for example, or influenza, etc. But it's probably a minor effect if the effect will be found. From our study, we cannot contribute that much, but out of the 372 patients which were managing in countries vaccinating, 9% were vaccinated and 9.7% were not vaccinated. But in spite of this, of course, all of them got COVID as they were enrolled in the study. Okay, now let's look at what is probably most dramatic, which is the impact on health services, right? And the first thing, again, is to recall that more than 70% of the patients had active TB, but 28.6% had sequelae, so the so-called post-TB lung disease. And this is a risk group clinically relevant, which basically, if we decide, we realize it's important to assess it and manage it, and eventually undergoing a rehabilitation for the patients which need them, which we need it, which, by the way, rehabilitation works, right? This is will represent a burden on health services. So these patients will have a, let's say, a potential cumulative effect of the post-TB disease and post-COVID disease. And of course, the importance of addressing this, testing the patients, at least those with more severe signs and symptoms, impairment of the exercise capacity, they cannot climb the stairs anymore, etc., and with impaired quality of life, then this group represent a relevant analyzed. But of course, this will generate further work and further, let's say, even for programs, right? And because of this, the UNES just completed a first document with the clinical status, the evaluation of these patients and the rehabilitation of these patients, which will be published open access in the October issue of the International Journal for Tuberculosis and Lung Disease. And it's an issue which is becoming more and more important. In terms of absorption of resources, we see that oxygen was necessary for more than 1/3 of the patients, that 12% of the patients needed ventilation, non-invasive, and 8% needed invasive mechanical ventilation. Of course, this generates quite some problems on the ICUs, on the countries concerning the availability of monitored beds, etc., on the stock out of oxygen, availability of ventilators, and also on the staff which are supposed to take care of these patients. This is a picture. So, you know, Italy after China had, let's say, it was the first country facing a big wave of COVID-19 in, let's say, February, March 2020. And there was developed a specific new a kind of intensive care unit at the Fiera di Milano, in Milano. And the main difficulty at the beginning was both to identify staff, because basically all the staff with specific competencies on, let's say, invasive care, ventilation, etc., were already busy and already at work. And also the difficulty to equip the department with ventilators, because the capacity of producing ventilators in Italy and overall was not, let's say, coping with the needs and the request. And the another example is in Varese, which is my city, where there is a brilliant hospital, very modern and efficient, etc. This is an article which appeared in the Washington Post during the second wave, which was November 2020. This hospital for quite some time was under top pressure, and one of the main issues was, of course, keeping the other services in place, so being able to provide something else than COVID care, need for monitored ICU beds, etc., but also the oxygen supply, because the consumption of oxygen was so high because of the large proportion of beds transforming into COVID beds that even a modern hospital had problems to prevent stockouts. So having every day filling out of the, let's say, the big container of oxygen. And this has been described in different settings. So there was this famous situation in Amazonia in Brazil and in other settings as well. And the last question was, what stuff is in the front line against COVID-19? And this was an example. This is Mexico City, and is the team of Marcela Munoz at the INER Institute. This was a very well-equipped former MDR-TB reference center, which was equipped with negative pressure ventilation room, monitoring beds, etc., which was transformed, maybe permanently, not clear yet, into a COVID hospital. And then it was not fully clear which the destiny of the patients was, as the reference center was not moved to another place. So potentially, and this was a situation in other countries, this could lead to an issue in the diagnosis and management correctly of TB patients. The experience from Sierra Leone with a clear decline in TB diagnosis after April 2020, and the possibilities, as an article by McFoyd in the Union Journal, which shows in the different steps of the latent TB infection cascade, you know, from the selection of patients to the, let's say, end of the treatment of TB infection, which can be the factors which can negatively impact the management of latent TB infection, but potentially can also boost it. And there are several elements. Some of these elements are on vulnerability to TB and TB transmission, as underlined in the paper. Because of this, the GTN started a first study on health system, which analyzed, comparing the period February and March 2020 versus the pre-COVID year 2019 in 16 countries, looking at the number of examinations period versus the preceding year. And we see, for example, this is active TB, India and the Philippines. We see the arrow here, and there is a clear decline in the diagnosis in India and the Philippines in following the lockdown, which is represented by the arrow. And again, this was the same. This is TB, same situation in Mexico, in Argentina, in Brazil. For active TB, again, Africa, Kenya, Niger, and Sierra Leone, largely. And for active TB, situation in Russia, similar. For latent infection, again, Mexico and Brazil, similar situation. Again, Sierra Leone and Russia, similar situation. So this has been confirmed by WHO, which in its 2020 report has included, let's say, this situation from India. And after the lockdown, there was a fall in diagnosis of TB, both in the public sector and in the private sector. So that even the WHO says, look, we have probably to revise the previously projected 50% reduction in death, which was forecasted because COVID is working on this. We have now done a second study, more advanced, which is at the moment pre-accepted by EHA, so we hope will be accepted soon, which has extended the number of centers, 19 countries, and the number of variables. So number of telehealth examination, TB cases, susceptible resistance, but also patients hospitalized versus managed as outpatients, and latent TB infections, not only the number of patients, but also the number of examinations. And those are the preliminary results. So we see in red 2020 versus 2019 in azure. We see less cases diagnosed, less cases discharged, less cases with drug-resistant TB, less cases managed by ambulatory phase, with, in the majority of cases, a kind of rapid decline we can see corresponding to the first wave in the spring of 2020. For the number of cases who died, a bit less died at the beginning, but in 2 points, the curve of 2020 crosses the curve of 2019, like we can see 2 waves there in a way. And there is an increase of the telemedicine, which has been, of course, moved by, let's say, the need of looking solutions to the problem of the underdiagnosis. In terms of latent infection,
Professor, we've got 1 minute left.
Yes, I'm going to conclude. We have also infections diagnosed, and if you remove Russia, which has a different pattern, we see that we have also a lower number of IGRAS and TST done overall in 2020. So, I mean, we have here the situation in different countries: Mexico, the same, Brazil, Niger, the same, and for latent infection in Europe, France, Italy, Spain, and United Kingdom in red, less latent infections consistently. And in a few countries like Virginia is the opposite, more cases diagnosed, and also in Singapore, the reason is good services, sensitization for COVID, so more TB are diagnosed in these 2 countries. I want now to thank all the collaborators from the different societies which have participated, and the over 200 participants without whom this exercise could not be done. And we come to potential questions. The main question is if you are going to expect a new U-shaped curve of concern, and which are the implications for countries, and if it is the moment now to invest on TB to prevent further problems in the future for TB. And then the conclusion. So I'm concluding. We had the evidence now that TB and COVID can be diagnosed at different times, that probably the COVID is less brilliant than HIV in boosting infection, the transition from infections to TB, that the main determinants of mortality are age and comorbidities, that patients with positive lung disease and sequelae post-COVID are emerging as a group at risk, that we need quality prospective studies and improvement of infection control. And this is the last slide. There is a clear impact of COVID-19 on TB services. We have, let's say, countries with low burden and good services in which it was the opposite, so more TB was diagnosed in this phase. There is this important issue of rehabilitation, and there is urgent need to respond and invest now in TB services and improve infection control. So in a way, the question is, should we fear the double infections? And probably yes, right? So this is my conclusion. And now I'm ready for the questions.
Thank you very much, Professor Migliori. We have some questions in the chat box. So I will ask, since we only have 6 minutes left, I will ask for short answers. So we have a question from Dr. Sana Iftikhar. regarding case fatality rate. And she asks, what is the cause of different mortality rates in different parts of the world on co-infected participants?
Right. So according to what we have seen, age and comorbidities, now we are investigating this in particular. We have not finished the analysis of the big study because it's long-lasting story. But apparently, the most important risk factors are diabetes, the cardiovascular disease, renal disease, liver disease, and chronic respiratory disease, which also have a connection with age, because let's say people which are old in age have higher probability of having more comorbid, trying to calculate all the relative risk, etc., which takes a bit of time.
Okay, thank you. Another question, anonymous question, is who has more mortality in COVID-19 positive patients? Active TB patients or patients with post-TB lung disease?
Can you repeat? Patients with TB or?
Who has, I guess, higher mortality of those with COVID-19, of those COVID-19 positive patients? Those with active TB or those with post-TB lung disease?
I think those with active TB, right? So in some countries, we have seen California. Apparently there is no difference, but this is a very specific situation. I think in general active TB, but if the sequelae are very severe, this can represent an additional issue. So what we are doing now is to analyze carefully the level of, and the severity of the post-TB lung disease, because this can be very severe. So probably we can say those with active TB and the sequelae with advanced commission, if you want. So those are probably the two groups. We need to analyze a bit more.
Okay, great. Thank you. Another question. How long is it recommended to do radiological follow-up in patients who had TB and COVID-19? What radiological characteristics are more relevant?
Yeah, this is very good. From which country is the question coming?
I think it was an anonymous question.
It's anonymous, okay. This is a good question. Now, do you know that WHO has recommended, let's say, the definition of cure and treatment success? So it's at the moment of the end of TB treatment, right? But there was a revision of some of these definitions, and WHO says, whenever possible, let's extend the period of observation. So if a cohort has the possibility to be followed up, let's follow it for more time because we can learn from that. Now, I think that the answer to this question is that each country should do what is possible to do. So I don't think that countries which high burden, India or China, can follow up all patients for 1 year or 2 years, right? Maybe a country like the Netherlands, which have few cases and resources, can do that. Probably it is important to follow up the patients which have sequelae which are more severe. So when a patient at the end of TB treatment has clear lungs, goes well, is probably not. But if a patient has restrictive or obstructive damage, cannot climb the stairs anymore, has problems to undertake normal activities of normal life, etc. So those patients might need to be followed up more often. So it's more an issue of severity of the individual patient and also feasibility in terms of the resources available in the country, which we know, unfortunately, are not the same in all countries.
Okay, thank you very much. So we have one last question from Sudhir, let me just check, Lohani. He asks, do you think more TB cases could be incidentally picked up during post-COVID surveillance radiology?
Sure, sure. So we have seen that there were, let's say, coexisting phenomena, right? So generally, and we had more than 20 countries in our study, right? So there was a decline in diagnosis, etc., because people either were fearing to report to health services. They say, I fear to go to the hospital to get COVID, or the health services were overburdened and TB activities were, including screening, etc., were not done properly. So those can be reasons for that, right? But in some countries, the with health services not very much stressed, or etc., where incidence of COVID and TB was not that high, etc., the attention to people coughing, etc., because of COVID, brought send the patients to make a CT scan and radiology, and eventually CT scan, and then TB appeared. So ideally, we have to use all opportunities we have to look for both diseases, thinking that signs and symptoms are the same. So we have to keep the eyes open and consider also the history, of course.
Okay, there are more questions, but unfortunately we are running out of time. So I think we have to finish here. I think all these questions that the audience is posing now or writing in the chat box is a sample of the interest that this seminar has activated. So I think now I have to really thank you very much, Professor Migliori, for your comprehensive presentation on this dangerous combination, COVID-19 and TB. Thank you also to Ali Merzuk for the technical assistance for this webinar. And thank you to all the attendees. We had colleagues from dozens and dozens of countries from all around the world. I think this is exciting, and thank you for your participation and interest. So we look forward to seeing you in the next webinar of the European Respiratory Society. Thank you very much and have a good evening.